My name is Dr. Caleb Kaufman. I'm a doctor of physical therapy. I've been practicing for 6 years now. I started in Virginia, moved out to California, and decided that typical physical therapy was boring. I didn't like seeing 4 people at a time. I didn't like seeing 20 patients at a time. So I started my own clinic where we do one-on-one sessions, we do hour-long sessions, and it's just you and the physical therapist. That way there's not a student physical therapist or a aide high schooler telling you what exercise to do. So we're very focused on quality treatment, getting people better. Once I started doing that, I realized that there was a lot of holes and gaps in our current physical therapy trend. So I started integrating more strengthening barbell movements into my physical therapy treatment. So some of this stuff, even though it seems like this is tailored specifically for a gym, this is actually what I do in the clinic. And it seems to work out really well for people who've never even touched a barbell before. We can get you moving better, stronger, and out of pain. So the ultimate goal today is to help at least one person get out of shoulder pain. I want you guys to not feel better. I don't want your shoulder to feel better. I want you to feel better over 20, 50, 75 years so that when you're 90 years old, you can be that Instagram model doing the overhead press. And everyone's like, wow, I want to be just like that. Because that's really our goal. Our goal is longevity. It's not to say that I can do this right now, right? Our goal is to say that we can run, we can stay active, we can play with our grandkids when that time comes. With our current healthcare model, a lot of times we wait too long, and then we try to retroactively fix everything. One of the biggest confusions is pain. Why do we have pain? Where does pain come from? So the first part I always talk about, if you've been here before, I think I talked about it last year with the deadlifting seminar, is my 5 myths of pain. There's one more this year, so 6 myths of pain. If you can understand why pain is there, you're going to be less scared of pain, you're going to have a better response to pain, and you're going to be able to recover from it much quicker. Okay? So the first one that I want to talk about is imaging does not equal pain. Especially true in the shoulder and the low back. Just because they find something doesn't mean that's where the pain is coming from. A lot of times, here's a normal pain pathway, right? We get injured. You guys do CrossFit-like experience movement, so the first step is to ignore it and hope that it goes away, all right? After that, it doesn't really go away, so you see a doctor. The doctor says, rest, medicate, it'll be fine. 2 months later, it's still there, so you go back and say, well, let's do an MRI. The MRI comes back and says that you have inflammation of the supraspinatus tendon. You're like, okay, here's more ibuprofen, here's an injection, it'll get better. It gets better for a little bit, and then it doesn't go away, and it just keeps coming back every time you try to resume. So what we're doing right there is we're saying we're trying to base our treatment off of an image. What you did actually is you started with pain last year. You took a whole year to try to diagnose it, and you're still not anywhere. Instead of saying, here's where the pain is because of the image, why don't we take a step back and say, why does that image say that there's dysfunction? If there's supraspinatus tendonitis, if there's biceps tendinosis, why is that there? What movement is wrong? Where's our strength wrong so that we can fix that? So instead of trying to fix the pathology and that diagnosis, we actually fix the underlying cause of it so that we can fix that. Now, honestly, if someone comes in with shoulder pain, typically 3 months and they're back to 100%. So we don't trust always. There's caveats to all of this, okay? Obviously, but don't trust the imaging as the be-all, end-all for your pain diagnosis and your treatment plan care. Number 2, amount of pain is the amount of injury. So let's say you're working out, you do an overhead lift, you have sharp shooting pain in your shoulder. You automatically think like your deltoid is torn off the bone and ripped the humerus off with it, right? Not always true. The amount of pain doesn't mean the amount of injury. So a good example of this, when I was 20 years old, I jumped off a flight of stairs and broke my ankle. I went to the emergency room, and what's the first question they ask you? How much pain do you have, right? So I said, I was like, no, 2 out of 10, because it didn't really hurt. Took an x-ray was negative, everything was fine. So I walked around for 6 months, ran a marathon, then found out that I had broken my ankle in January, and this was already September. I had a chunk of bone floating around. Obviously there was damage, but the amount of pain I was in didn't replicate the damage. So low pain, high damage, right? So let's look at the converse of that. Who's gotten a paper cut? Like you sliced your hand open, that's not a bad thing, but the amount of pain is super high. So just because there's high pain doesn't mean that there's damage. Now, sticking to the shoulder, just because there's a lot of irritability, the pain is high, doesn't mean that ultimately your rotator cuff is torn. A lot of times, I can't tell you how many times people come in and they say, yeah, my shoulder hurts, it's on fire, I'm gonna go get an MRI because I know for sure it's broken. There's something torn there. and it comes back and there's like, yeah, you have a little bit of inflammation in your glenohumeral joint, and that's it. Again, going back to the imaging, we don't want to wait for that. We want to get started now. So instead of going in and saying, let's get this and this and this, the normal steps, let's cut that in half. Number 3, location equals cause. Really good example for this is heart attacks. When you have a heart attack, where do you feel that? You don't feel it here, exactly. You feel it in the left shoulder. You feel it in the left arm for females. You feel it in your mid-back a little bit. So you go to the ER and you say, I have shoulder pain and I have back pain. And they start treating your shoulder and you're in all reality having a heart attack. So you want to treat the underlying cause of pain, right? Who's hit their funny bone? Your funny bone hurts and you feel it in these 2 fingers. You're not injuring these fingers. There's nothing wrong with these fingers. What you're feeling is the irritation of the ulnar nerve shooting down. So we have the ulnar nerve that shoots down to the hand. We have the heart that goes to the shoulder. Same thing with muscles. You have neck pain. You have headaches. It's probably coming from your neck a little bit. You have shoulder pain in the front. It's probably coming from the infraspinatus in the back. We have to look at the whole picture instead of just where the pain is. If you chase the pain, you're never going to get it better. It's always going to hurt and hurt and hurt. All right, number 4, lifting heavy is, what would you say, bad? Who's been to a medical doctor or a physical therapist and they said, do not do CrossFit because you're going to break down your body? Or do not lift heavy because you're going to break yourself? That's a bunch of crap, right? Because our body builds up to what we give it. There's something called Wolff's Law that when you apply stress to your body, the body will meet that stress and lay down more bone, muscle, connective tissue to become stronger. I just had someone tell me, another healthcare professional tell me this week that I should not be strengthening this individual because the stronger he gets, the more damaged he will get. And that's, that confusion is what hit me too, because it doesn't make any sense to me. He has chronic subluxations. If you have chronic subluxations, you want to strengthen those muscles. Because when we load the body, it doesn't just strengthen the muscle. There's been a lot of studies in runners and CrossFit athletes, weightlifters, that as we load, as we put weight through your body, the muscles get stronger, sure. But what we're also seeing is the bone gets stronger, the bone density increases. We've been told that running is bad for your joints. Yeah. So everybody, right? They did a study from 1985 to 2015, so 30-year study. They did x-rays and imaging on 2 groups, on runners and non-runners. They let them live their life. 30 years later, they came back and took imaging of the same people. What they're looking for is arthritis in the knee joint. So runners and non-runners, just off the top of your head, who do you think had more arthritis, the runners or the non-runners?
Non-runners.
What do you think? Non-runners, exactly. The non-runners had more arthritis because there's more degeneration. The runners, they had that compression daily. They had that growth daily, and they found that you have stronger bone and joint if you apply that stress to you. So we can extrapolate that and say, with CrossFit, with weight training, with strongman competition, anything, as we load the body, our body's going to adapt to that. It's all about what we condition our body to do. Like Lenny was saying earlier, if your biggest thing that you do is throw your purse over your shoulder, you're going to knock it out of joint. But if you're doing snatches, if you're doing kettlebell swings, and your body's used to being in this position and you get strong in this position, that little movement isn't going to bother you at all, because you've challenged your body to be this high, so everyday tasks that are this low are super easy for you. All right, number 5. Pain is always going to be there. I'm always going to have pain. And everybody said that at one point. I remember when I was 26, my back went out. I was on the floor. I couldn't lift my kids, and I thought, this is it. My back's stuck, and I'm just going to, be like this forever. You're not stuck with pain as long as you take appropriate action. If you listen to the right people, and if you do the right things, pain can go away. Now, that doesn't mean we're never going to have pain, right? Pain is a normal part of life. When we stub our toe, when we lift too much weight, when we do stuff, we're going to get sore, we're going to get painful, and that's fine. But we shouldn't think that we're stuck in this place of just always having pain, not being able to move, and not being able to enjoy our life. So throughout all of this, I know shoulder injuries are terrible. Don't ever think that you're stuck with it. There's always something you can do to make yourself feel better, to take pain away, and to get back to doing what you love. All right, so number 6 is the last one. Hurt equals harm.
Oh.
Sorry. I thought it was good. Pain is a discussion that we can have over the course of 6 months, 3 hours a week. There's actually courses in college that just cover pain. We're going to talk about it in 1 minute. The body has pain because it's a warning sign of harm. when you have harm, if everything's operating normally, you have pain, right? You break your arm, you have pain. But the opposite isn't true. When you have pain, you don't always have harm, okay? Just like all Labradors are dogs, but not all dogs are Labradors. That same mentality where all harm should equal pain, but not all pain equals harm. As we have chronic movement impairments and chronic pain, our body goes on high alert and it ramps up. It says sometimes to us, last time I did this movement, I had pain, or harm, excuse me. So this time, before I do this movement, I'm gonna have harm afterwards. So I'm just gonna give the pain signal preventatively so it stops the movement. So what then happens is that as we're moving in our limited range of motion, the body's on, again, this high alert system. Think about your home security on the highest setting, or your Ring doorbell. Those things are annoying because you can set it for like 25 feet and it just always goes off. So your alarm system is set to that length, and it's always saying, if something comes in this range, I'm just gonna give the pain signal. That's obviously not the case because we can move, we can have pain, but we're not doing harm. When you have your shoulder hurt and you're just sitting here and it aches and throbs, there's obviously no harm being done. But you're having the pain signal because the body is just giving those abnormal signals. So that was my soapbox on pain. Self-diagnosis is super dangerous. I've done it myself. My back was hurting, so I said, oh, it's my back, so I'm just gonna have people treat my back. It never got better until I started doing heavy deadlifts and heavy squats. So obviously it was hip weakness and mobility issues that were causing back pain. Why does this hurt? It could be your posterior shoulder referring forward. It could be your neck referring down. It could be actually bicep tendonitis, because that's gonna be right there. It's hard to say where it is without doing a full movement screen and strength screen. So with some of these screens, you're gonna go through them and it's gonna be weird. You're gonna feel like you're doing it right, but you're not. So we're gonna be super specific on how you're doing it to look at what does this motion do to the pain? How does it affect the pain? And then as far as like treatment, what we wanna do is the retest. Your shoulder hurts with overhead lifting, okay? Let's treat the shoulder, in the back of the shoulder, test it again. Okay, that's better, that means we're in the right spot. We treat it, it still hurts, then maybe we need to look at a different place. So it's a little bit of a puzzle, right? Shoulder hurts, what's the missing piece? Back of the shoulder. That piece wasn't right. Let's try the cervical spine, see if that works. And then we just go from there. As far as the treatment aspect of it, I see rehab, recovery, whatever you want to call it, in 3 stages. The first step is we have to alleviate the pain. If you have pain in your shoulder, you're not going to be moving right. Your body changes what muscles activate if you have pain or if it's expecting pain. We have to decrease that pain so we can understand what really is going on with the body. The second thing is fixing that underlying cause. And like we said, the pain is here. We have to decrease that so you can move, so we can get a good movement assessment. But then we keep digging. We say, okay, what is the exact problem? Why you're having this pain? Third step is plan for the future. I don't want you guys better, like I said, for 3 weeks, 5 weeks while you see me. The goal is to have this longevity so that you can keep doing this in the future. We're always gonna get hurt. We're always gonna have pain. We live dangerous lives because we're lifting, metal over our head. So it's gonna be dangerous, but we should have a plan for when the shoulder pain does come back. We know exactly, or the hip pain. We know exactly what to do. We're not gonna focus on the alleviating pain part. I do a lot of hands-on manual treatment for that. We're not gonna focus on the planning for the future part. Today, what I wanna show you is fixing that underlying cause. We'll go through a little bit of an assessment. With each assessment, there's gonna be a corrective exercise that we can do for that. We want mobility. We wanna be able to move into the right position. We want stability. We wanna get and maintain that position. And then we want strength after that, okay? So obviously the first thing we need to do is move correctly. If you can't get your arm overhead for an overhead squat, obviously something's gonna be wrong, so you gotta fix that first. If you can't keep the bar over your head because you don't have the stability, you won't be able to do an overhead squat. Once those are taken care of, that's when we really wanna start loading and adding more weight and resistance for that. So I'm gonna break it into mobility and then stability for each section. There's 2 bits I wanna explain to you. Each of them, like I said, has an assessment, it has a treatment. The first thing, obviously, when we're looking at the shoulder, this is when it gets a little nerdy. We have 4 joints. We have the sternoclavicular, we have the acromioclavicular, we have the glenohumeral joint, and we have the scapulothoracic joint. The first one we're gonna look at with mobility, we're gonna look at the glenohumeral, and we're actually gonna look at the spine with this too.